Hi, everyone. Thanks for joining us tonight. We're going to be talking a little bit about MASH and MASLD. And Rachel, I don't know if you've got to give me back control. There we go. It's not letting me. There we go. You guys that may know me, if you don't know me, my name is Christie Morrison. I'm a nurse practitioner in San Antonio, Texas, and I'm currently one of the lead APPs at Oshi Health, and also a nurse practitioner at Texas Digestive Disease Consultants in San Antonio, which is part of GI Alliance. You guys can use this QR code to record your attendance for the meeting, so you can take a scan at that, and we can always share it again later. But as I mentioned tonight, we're going to be talking about comparison of F3 and F4 fibrosis in MASH and MASLD. So we're going to present a case, and this is case number 6A, but we have a patient here by the name of Sam, who is a 55-year-old male, and he's been referred to our clinic today because he had some mildly elevated transaminases, and then subsequently his PCP ordered an abdominal ultrasound, which did show some increased liver echogenicity. And this is a very common consult that you guys may get in your clinic pretty regularly. The only complaint that he really has at this time is a fatigue. We do see, of course, his demographics here. He's 55, he's a white male, and he has a BMI currently of 33. Other past medical history for Sam are, of course, type 2 diabetes, hypertension, hyperlipidemia, sleep apnea. So several of those metabolic disorders that we worry about. We also do know that he does not use alcohol, so that's not a contributing factor to any of our problems that we're going to be talking about tonight. We see on his medication list that he does take lisinopril for his high blood pressure, rosuvastatin for his hyperlipidemia, Zetia for his cholesterol as well, and dapagliflozin for his diabetes. We do a physical exam and we see that he's got an obese abdomen, but he doesn't have any tension. His belly is nice and soft, non-tender. When we percuss, we don't see any signs of enlargement of his liver or his spleen. So let's look at the labs that he initially had. Of course, on vitals today, we see he does have a little bit of elevated blood pressure. Not anything crazy, but that, can be a sign that his blood pressure is not well controlled. Resting heart rate is pretty normal at 76, temp is normal, weight is 235, and of course that BMI is calculated at 33. When we take a look at his liver enzymes in particular, we do see that elevated ALT and AST, and alk phos is a little bit on the higher side of normal. Platelets, although technically are normal, are on the lower side of normal too, so that's kind of a warning flag for us there. Then might be something going on with his liver. Total bilirubin, again, pretty much kind of still technically normal, but a little bit, something we would want to watch if it starts to climb above that 1.1. We see that his A1C is 7.1. Although he does have diabetes, our goal is to get that A1C less than 7. So a little bit of uncontrolled glucose and blood sugar there. And then when we look at his other metabolic panel, we see that he's got a creatinine of 1.1, maybe a little bit of chronic kidney disease secondary to his high blood pressure and diabetes. INR is good, so no clotting or coagulopathy at that time. Ferritin is elevated at 780, so that's a little bit higher than we normally see, which could be a sign of inflammation, but just something to keep in mind. Iron saturation otherwise is normal. ANA may be a little bit elevated, but we see that smooth muscle antibody is negative, and he doesn't have any signs of acute viral hepatitis. So for this patient, we decide to do a fibrosis assessment. So what are things that we're going to use to do that? We can definitely calculate a FIB4, and that's easy to do just from the labs that we already had in place there with his AST, his INR, platelets. So we get the FIB4 score, and it is on 2.74, which when we calculate that out, it determines to be an intermediate risk, right? So because of that, normally, we would go ahead and order an ELF. Sometimes, depending on the lab that you're using, if you've ordered a FIB4, it will reflex to an ELF. And because of that, we're also wanting to go ahead and get a FibroScan to make sure, that we're not missing some fibrosis that may not be definitely determined on these blood work. When we get the FibroScan, we see that he's got a KPA of 11, which definitely is concerning for fibrosis, F3 fibrosis to be exact. CAP is 262, so that's an indicator of the amount of steatosis in this individual. And as it is 262, it's pretty high, right on the border between moderate and severe steatosis. So we know we've got some room to work there as far as decreasing fat as well. Then when we got that ELF score to really give us a better serum score related to his fibrosis, we do see that it's pretty elevated as well, above a 9.8, which makes us concerned about severe fibrosis, but not necessarily to the point of cirrhosis at this time. So is there any testing that you'd like to perform on this patient? Anybody can answer that for me? Any concern that any of his test results may be inaccurate related to some of his other comorbidities, or maybe his body habitus, something you think about?
Would you feel inclined to test him for hemochromatosis?
You could definitely do that with that elevated ferritin. That's a great call out there, Heather. Typically, you see that in combination with a high iron sat as well, but it's not a wrong answer to do. And with that kind of elevated ANA, certainly something we could rule out as a cause of his fibrosis. We definitely know he's got some other risk factors though as well. So we don't want to discount those other risk factors, but still it's certainly something that we could check pretty easily with a blood test. So good call out. Anything else that anybody else might want to order for him? I'm going to go back to our FibroScan. It doesn't really show the FibroScan IQR here, but if you guys have ever read FibroScans, one thing that you want to look at is an IQR. The IQR will really tell us how accurate the FibroScan results are. Depending on body habitus, sometimes a FibroScan may be a little bit more difficult to read for steatosis and fibrosis. So if we were really concerned if that IQR was too high, that might indicate that it's inaccurate. And we might want to get an MRI elastography, which will give us a little bit better picture of fibrosis in this individual. But we don't know here, so I'm going to assume that it's accurate and giving us a good picture with that 11 KPA. But that might be the other thing that I would consider ordering here. So how would I stage this patient based on the current results that I have? I definitely can say that he's an F3 fibrosis patient. Do you guys all feel the same, or any concern for any higher scoring? Okay, great. We'll move on. So now we think he's got F3 fibrosis. What do we do to treat this patient? Specific recommendations from anyone? Well, we know for fact that he's got an elevated steatosis score and a fibrosis score. We're not quite to cirrhosis yet, so that's good, but we really want to be aggressive with his treatment to prevent that fibrosis progressing to cirrhosis at this point. We've already got some concerning labs. We definitely know that his blood sugar is a little bit poorly controlled, so we can counsel him on that, maybe talk about Mediterranean diet. If he's not seeing a diabetic dietitian already, that could be a start to help him get his blood sugar under control. We could discuss with his PCP adjusting his diabetic medicines in addition to diet and lifestyle as well. This patient with an F3 fibrosis, already lower platelets, I would definitely want to make sure that we are using probably Rezdiffra at this point too. He's already pretty far advanced in his fibrosis score. We don't want him to be that person that tips over to the edge to cirrhosis. And unfortunately, because of how advanced his fibrosis are, we're right there. And knowing that he already has uncontrolled diabetes, we really, like I said, want to be a little bit more aggressive with this patient. So I think Resmetirom would be a great option to start here. Again, talking with this PCP about adjusting diabetes medicines if we need to, maybe even his high blood pressure medicines because of that elevated result. Of course, that could be white coat hypertension as well. But again, he needs some more monitoring and adjustment there. Also, As I mentioned, lifestyle modifications are going to be big here. We can use Resmetirom, but if he goes out and continues to eat a poorly diet, which we don't know what his diet is at this point, but we need to really get a better history there and make sure we are counseling him on lifestyle modifications alone, because at this point, we need to be aggressive. We need to, what I would say, have a come to Jesus meeting with this patient, because if we don't get this under control soon, he's going to progress to that cirrhosis. And of course, unfortunately, we know there's no cure. So then how would we monitor this patient? So if we do start Resmetirom, we definitely need to get some thyroid studies. So we need to make sure his thyroid function is okay here. Unfortunately, that is a contraindication if he were to have some kind of underlying autoimmune active thyroiditis that's not very well controlled, okay? Otherwise, we could monitor him through lab work. So some of the abnormal labs that he had before, we want to definitely make sure we're checking those again. With Resmetirom, we want to be careful not to check the LFTs too quickly. So sometimes we'll see Resmetirom cause actual elevation in liver enzymes over that first 4 to 6 weeks. So we want to make sure we're checking more closer to the 12-week mark there. As his diabetes isn't well controlled, we may want to consider a GLP-1 medication. And we know from our studies that patients in combination with Resmetirom and GLP-1s did really well as far as decreasing fibrosis scores and decreasing weight. And then because he is already at stage F3 fibrosis, we want to go ahead and start monitoring him for HCC. We don't actually have definite guidelines that state that we have to do that at this point, but it's good practice and considered to be pretty standard. So he could progress to cirrhosis and develop HCC pretty quickly. So we want to go ahead and start that every 6-month screening with either an ultrasound and Dopplers to make sure that we're checking for any elevated pressures, and either if he's not able to visualize the liver good, then we might even consider doing an MRI of the liver as well, or definitely if there's any concerning lesions already. So now let's think about this same patient profile, but we're going to have a little bit of different labs. So again, we've got Sam, 55, male, Caucasian, overweight, history of type 2 diabetes, high blood pressure, hyperlipidemia, sleep apnea. Again, all of those metabolic disorders that make us more concerned about development of MASH and cirrhosis from MASH. We see again, same findings on physical exam, obese abdomen. His abdomen is soft, non-tender, it's not tense, so we're not seeing any signs of advanced liver disease at this point. Percussion, we're not seeing enlarged liver borders or splenic borders. And medicines are the lisinopril, the rosuvastatin, and Zetia and dapagliflozin for his diabetes. But our labs are going to be a little bit different this time. So blood pressure is still elevated, resting heart rate is still normal, temp is normal, weight is the same. But when we take a look at this ALT and AST, still elevated similarly, and alk phos is still elevated, but total bilirubin is a little bit more elevated this time. Platelets are also now definitely not within normal limits anymore. They're lower. A1C is the same. We look at creatinine, that's also a little bit higher. So definitely some chronic kidney disease. Sorry, this flipped off. Get back there. Ferritin is still elevated, which again can just be related to an inflammatory process in the body, but we might want to consider checking for hemochromatosis, as Heather suggested. ANA is definitely, again, kind of like borderline elevated there, but smooth muscle antibody and his viral hepatitis panel all negative. So non-invasive testing scores. Now let's look at this FIB-4 score again. 3.36. So remember, we're calculating FIB-4 with liver enzymes, platelets, and automatically from the get-go, this is a higher risk patient concerning for fibrosis. We can still check an ELF as well, just to be sure. And we see his ELF at the bottom is 11.4, which is now concerning for cirrhosis of the liver. When we get that FibroScan result, 21, which is definitely concerning for advanced fibrosis. Anything over 20, we really think about cirrhosis in that patient. And then his CAP score is 245. mild steatosis here instead of in the previous patient where it was more moderate. But despite that lower CAP score, we're still seeing signs that are all consistent with cirrhosis of the liver here. With the elevated ELF, elevated FIB4, FibroScan over 20 with the KPA, and then we saw the lower platelets. All signs that are concerning for advanced fibrosis and cirrhosis secondary to MASH in this patient. So now, is there any further testing that you'd like to perform in this patient? I think we're still okay to check a hemochromatosis score like you talked about there before, Heather. Anything else?
Did we have an INR?
We did have an INR, and I think it was 1.4. Let's go back. No, it was 1.0, so still normal, so that's good.
Would you consider doing an upper endoscopy?
Absolutely. So when we have anybody who has abnormally low platelets and that fibrosis score that's concerning for cirrhosis, definitely we want to go ahead and do a variceal screen here. So that's a great call out. Yes.
How do you feel about the new guidelines trying to do like less invasive screening without an upper endoscopy?
I think we can do that for some patients, right? And if he were not to have those low platelets, I think we could probably get away with it. But because we've got lower platelets, this patient is higher risk for bleeding. Okay, so he's one that we don't want to assume that he doesn't already have any kind of signs of portal hypertension. We don't have, Dopplers from an ultrasound yet. So again, based just on the KPA and the lower platelets, yes, I absolutely would. But I agree, if you didn't have other signs of portal hypertension with like a lower platelet score, I think we could forego variceal screening in this patient. Any other thoughts or testing that we should do? I mentioned one, we definitely have got to get an ultrasound. We've got to do some HCC screening for him. I would get Dopplers at that time. Again, looking at the portal venous Dopplers, make sure we're not seeing elevated pressure there already. And that's something they can do at the time of ultrasound that's still non-invasive.
Are you doing mostly all of your ultrasound for HCC screening with Dopplers?
I am.
Okay. Every 6 months you're doing it with Doppler.
I am. We don't necessarily have to do Dopplers if we already know he's got varices or signs of portal hypertension already. So if this was a patient coming to me that already had ascites, probably wouldn't necessarily have to do Dopplers at that point, right? We know he's got portal hypertension. But in the absence of any known signs of portal hypertension other than that potential of low platelets, yeah, I go ahead and do it just part of my standard screening. That's not absolutely required. It's just something that I do as part of my practice.
Right. And is that even in your F3s?
Yep.
Yeah. Okay.
That's a good question though. Anybody else with any other questions so far? All right. So how would we treat this patient now? We cannot use Resmetirom in a patient that we suspect cirrhosis in, so we're not going to use it here in this patient. Unfortunately, we've already progressed to the point where it's no longer going to be viable to help us, prevent cirrhosis because we're there. But we still can work on dietary and lifestyle modifications. In my practice, every cirrhotic patient gets a nutrition referral. We didn't see an albumin on these labs, but that's something we want to monitor closely in cirrhotics because if we're starting to see albumin, that's another sign that he could be decompensated, right? So if albumin is dropping, kidney function is rising. So we're really going to counsel him on really tight control of his high blood pressure, really tight control of his blood sugar as well. Still might consider a GLP-1 for him because weight loss is still going to help prevent other complications from already cirrhosis. If he ever progresses to the point where he could qualify for a transplant, if he's at a healthier weight, blood sugar is better controlled, all of those things decrease risk from transplant, right? Might make it a little bit easier for him to get a transplant, but also could prevent decompensation from his cirrhosis. So definitely want to make sure we're still working on all of those dietary lifestyle modifications for him, managing his hypertension, managing his diabetes, managing his cholesterol. Unfortunately, MASH cirrhosis does have increased risk of heart disease as well. So all of those things will further decrease that risk as well as worsening of his cirrhosis. This is a patient we are going to be monitoring every 6 months with ultrasound for HCC. So if we get it now, everything looks good. We're going to be setting him up automatically for ultrasound again. If for whatever reason there's an abnormal lesion, we might need to get an MR, elastography, or an MRI of the liver with maybe an HCC protocol, depending on if there are lesions present. And then if we do an EGD and he's got some varices, then we're going to be, starting him probably on some variceal prophylaxis with a non-selective beta blocker. If he starts to develop signs of ascites, of course, then we're all moving into unfortunately, the decompensated range at that point, which changes our management. So we said diet and lifestyle, screen for the varices, monitor for HCC. We're all going to be working on those. So let's look at these differences here. Where's the big differences on those baseline labs that really moves him into that F4 fibrosis? Of course, it's really the liver enzymes and the platelets, right? So that's where that FIB4 score initially can kind of give us an idea. If we calculate that just based off of the liver enzymes and platelets, we're already pushing higher into that FIB4 score. Technically, we didn't have to do an ELF at this point because it was already concerning, so we could jump straight to elastography, but it's never going to hurt you to do an ELF, and of course, it confirmed what we already were suspecting. But in the patient with the lower FIB4 score, I definitely would get an ELF to kind of help us do one more non-invasive testing before we put him through an ultrasound, and just to further kind of back up our F3 scoring there for him. Sometimes FibroScans can be a little bit more difficult to find too, depending on where you're located. If the patient is more rural, it's much easier to do a blood test at that point. And then sometimes we might even have to do an ultrasound elastography if we can't find a FibroScan. So in these cases, we can clearly see the differences based on the F4, the ELF, and the KPA scores that really differentiates that F3 and F4 fibrosis. So how do these two patients compare in management? Very different, hopefully forever, right? So if we've caught this patient with the F3 fibrosis, we've got some time there that we can be aggressive and hopefully reverse some of that fibrosis by using Resmetirom, getting his glucose under control, maybe working on some weight loss with a GLP-1 to control the blood glucose, but also help with his weight loss. And so we're still going to be pretty aggressive in treatment with both of them, right? So we can prevent worsening from decompensated liver disease in that F4 patient. But in the F3, we've got a little bit more hope that we can potentially prevent cirrhosis there. As far as non-invasive testings to differentiate between the two, FibroScan, I think, is really the most accurate and the gold standard there. But in indeterminate, and especially an indeterminate non-invasive test. So like if we get a FIB4 or an ELF score that's kind of in that indeterminate range, that's definitely where I'm getting a FibroScan or some kind of elastography for that patient, depending on, again, body habitus, size, what we have available nearby them. If they're in a rural location where they can't get to a FibroScan, I'm probably going to send them for imaging with like an MR elastography at that point. And then when is HCC surveillance important? Once we get to that F3 fibrosis, right? At any point, that person could push over to cirrhosis. We want to go ahead and start surveilling at that point so we've got a good baseline and we can hopefully pick up anything that would turn into HCC pretty early to prevent worsening complications. So that's it for our presentation tonight, talking about F3 and F4 fibrosis and comparing those two. Please scan this QR code to visit our GAP MASLD MASH community network and to talk about our disease state education along with a Rezdiffra promotional program there. Thank you guys for attending so much.